Welcome to today's weekly nugget. As always, this is for informational purposes only. If you're going to implement recommendations or information, education from this call, please speak with your primary care provider first. And we do our best to make sure things are accurate at the moment of recording, but if you're watching this in the future, make sure you look for the most up-to-date information before taking action. And so I'm really excited about today's call because I want to discuss glutathione. And glutathione is relevant for anyone that's breathing because it is the master antioxidant in our body. It's a Swiss Army knife. It does and performs all kinds of functions, which we'll cover today. And then right now, July 8th, 2020, of course, the COVID discussion is still top of mind for many people. And there's information coming out that glutathione sufficiency or not having a glutathione deficiency can prevent severe cases and deaths from COVID. And we'll get into that as we go. But first, I want to build the case for glutathione and help you understand what it is, why it's so important. So this first study is a 2003 study, and this is just looking at glutathione as a molecule. And what the authors tell us is that glutathione is a ubiquitous thiol-containing tripeptide. So it's a protein, or almost a protein, which plays a central role in cell biology. It's implicated in cellular defense against xenobiotics and naturally occurring deleterious compounds or toxins, such as free radicals and hydroperoxides. So thiol-containing tripeptide means it's sulfur-based and it's an antioxidant. Every cell in the body requires glutathione, as you'll learn right here in red. Glutathione status is highly sensitive indicator of cell functionality and viability. So the more the optimal glutathione status gives you optimal health from a cellular level. And since you're made up of trillions of cells, the more of your individual cells that have optimal glutathione status and are healthy, the more healthy you are as a whole organism. Its levels in humans range from 0.1 to 10 millimoles, being most concentrated in the liver, spleen, kidney, eyes, red blood cells, and white blood cells. In humans, glutathione depletion is linked to a number of diseases, including cancer, neurodegenerative diseases, as we'll get into, and cardiovascular disease. And you're also going to find that the immune system doesn't function well without it, especially your antiviral, antibacterial, anti-infection arm of the immune system, which is called the Th1 arm of the immune system. There's a piece in here that I want to show you discussing glutathione. So you'll see down here, it is well established that a decrease in glutathione concentration in humans may be associated with aging and the pathogenesis of many diseases, including rheumatoid arthritis, muscular dystrophy, ALS, AIDS, Alzheimer's disease, alcoholic liver disease, cataracts, Werner's syndrome, and then in red here I have highlighted respiratory distress syndrome. Why is that important? Well, from a COVID standpoint, remember early in the whole situation, the narrative was that they didn't want the healthcare system to be overwhelmed. They didn't want hospitals and respirators to be full because what they were thinking was the SARS-CoV-2 virus was going to cause ARDS, acute respiratory distress syndrome. So if glutathione deficiency is a well-established driver of respiratory distress syndrome, then it would make sense to investigate each patient's glutathione status to make sure they have optimal glutathione levels, or to replete those if they don't. It's well known in asthma research that asthmatics have deficiency in lung levels of glutathione, and giving glutathione to asthmatics helps reduce the asthma and or eliminate it totally. So glutathione plays a huge role in the lungs, a huge role in respiratory distress syndrome, and therefore acute respiratory distress syndrome, and therefore COVID. So we need to be looking at that. Next study. This is in the journal Immunity, and it's a cool picture if you're a nerd like me, but the take home is that glutathione is an antioxidant. So when your T cells, which are the cells in your adaptive immune system that are seeking out COVID or seeking out cells that are infected with COVID to kill them, those cells kill infected cells by creating what are called reactive oxygen species or free radicals. And so if they overproduce or they continue to produce after the infected cells are destroyed, now they could be damaging self-tissue. So glutathione is there as an antioxidant to be our anti-rust molecule or stop the oxidative stress once we've done the sufficient job of clearing infection. Glutathiones also, you'll see down here at the bottom, promote T cell growth. Again, T cells are major players in our adaptive immune response and in our anti-infection immune function. So if we don't have glutathione, you're not going to promote T cell growth and you're going to lack the adaptive immune response. So the infection could get a hold and possibly go septic, or in the terms of COVID, go more severe and even cause mortality. Glutathione drives the Th1 immune response, big time in fighting infection. This study talks about how do we make glutathione. Glutathione is present in all mammalian tissues as the most abundant non-protein thiol that defends against oxidative stress. So it's a non-protein, it's a tripeptide, which is not quite a protein, okay? And in all mammalian tissues, so all of our tissues, all of our dogs' tissues, all dolphin tissues, right? All mammals. It's a key determinant of redox signaling, vital detoxification of xenobiotics. So xenobiotics are toxins from the outside world, which we're exposed to all day, every day. It regulates cell proliferation or cell growth, cell apoptosis, which means programmed cell death. Therefore, glutathione plays a role in preventing tumor and cancer cell development. If you have sufficient levels of glutathione, it's promoting apoptosis of cells, or what apoptosis means, programmed cell death. So the cells run its course, it's time to die. If it lives longer than it should, now it's multiplying from a tumorigenic or carcinogenic standpoint. And fibrogenesis. So glutathione plays a role in creating scar tissue. Excuse me. In the production of scar tissue. So if you have a surgery and you need to heal, you need to form scar tissue, you need glutathione to heal properly. There is increasing evidence that dysregulation of glutathione synthesis contributes to pathogenesis of many pathological conditions. Again, these include diabetes, lung and liver fibrosis, alcoholic liver disease, gallbladder injury, endotoxemia, and drug-resistant tumor cells. So even tumor cells that drugs can't kill, perhaps if the patients had sufficient glutathione, they'd do better. Endotoxemia is important because that is occurring at the gut level. So if you have high intestinal hyperpermeability or leaky gut, endotoxemia can occur, and that's when bad microbes and their metabolites like lipopolysaccharide enter your blood and drive systemic inflammation and all kinds of issues there. So glutathione helps prevent endotoxemia, helps prevent optimal barrier integrity at all levels. So we talked about how lung integrity was important for respiratory distress syndrome, for asthma. Well, gut barrier integrity is important to keep all outside from your inside. Blood-brain barrier is important, right? Sinus barrier is important. Gum barrier is important. So glutathione is key to barrier function body-wide. This study looks at how glutathione is a biofilm disruptor and improves antibiotic efficacy. So if you have an infection, what this study found is that glutathione works to help antibiotics be more effective at clearing the infection. How? Many microbes can make what are called biofilms. And biofilms I picture as an igloo that they build to hide under so that they're not detected by the immune system or by our testing methods. So antibiotics were created before we knew about biofilms. Antibiotics were created to deal with free swimming bacteria, okay? So they're very effective if you dump them in the system and there's free swimming bacteria with no protection, the bacteria get killed. But we didn't know about biofilms back then, and what we know now is biofilms protect bacteria from antibiotics. So the antibiotics don't do well at penetrating the biofilms. They may knock some shingles off the roof, but they're not going to get all the way through. So knocking shingles off the roof can decrease symptoms of the infection, but it doesn't get the persister cells that are down deep. So you may take, say, vancomycin for an infection, you feel better for about a month, the infection comes back, you take vancomycin again, you feel better for about a month, the infection comes back. That's a classic example of a biofilm infection. You're just knocking shingles off the roof. You're not getting to the guys in the basement, okay? Well, this study shows us that levels of 30 millimoles of reduced glutathione or higher cause a 50% or more decrease in the growth of all bacterial species and their biofilms. So when they just gave 10 millimoles of glutathione, it didn't have an impact on inhibiting growth of the infections or disrupting biofilms. When we brought people's levels up to 30 millimoles or more, now we have a 50% or more decrease in the growth for all bacterial species and a significant reduction in biofilms as well. So again, from an immune standpoint, not only does glutathione promote a Th1 immune response, so promote optimal detection and killing of infection, but it also rips the roofs off the igloos and makes it more easy to kill those infections. And now we're getting into more COVID specific. So this came out just a couple weeks ago in the Journal of Infectious Diseases. And this is a hypothesis written by this man, but basically his hypothesis is that endogenous deficiency of glutathione is the most likely cause of serious manifestations and death in COVID-19 patients. So he says, higher rates of serious illness and death from coronavirus, SARS-CoV-2, COVID-19 infection among older people and those who have comorbidities suggest that age and disease-related biological processes make such individuals more sensitive to environmental stress factors, including infectious agents like coronavirus, SARS-CoV-2. So that's a mouthful. But basically what he says is that the elderly, the high-risk COVID groups, right? The elderly and the elderly plus comorbidities, or not necessarily elderly, but one or more comorbidities, are at higher risk of COVID. And it's because of biological processes going AWOL due to environmental exposures, stress, lifestyle, all the things they're being exposed to. But then he says specifically, impaired redox homeostasis and associated oxidative stress appear to be important processes that may account for increased individual susceptibility to diverse environmental insults. So again, in English, he says, our lifestyle and the environment, all the bad things we're faced with, knock everybody down. But more specifically, knock down the elderly and people that are more sick. So the more conditions you have, the more at risk you are from our current world, okay? But now he says more specifically, if you have impaired ability to deal with oxidative stress or rust or free radicals, aka you have poor antioxidant defenses, aka poor glutathione, then you are more susceptible to those things. And from a COVID perspective, here it is in an image. So if you have glutathione deficiency, then you have a range of response to infection. So say you have exposure to SARS-CoV-2 or the virus that causes COVID, right? You're infected. Now the virus can replicate to the level that the viral load is so high that you now have ARDS, right? Acute respiratory distress syndrome, and may even advance to death. Glutathione deficiency is going to drive you farther down the red, okay? Or if you've read my book, farther down the gray to the black, right? Same idea. So if you have glutathione sufficiency, then your T cells are doing better, your Th1 response is doing better, you're stopping any biofilms related to the infection. And yes, you may become infected, but you clear it, and you're one of those people maybe that test positive and didn't even know you were an asymptomatic case, or maybe you're someone that has the mild symptoms that feels kind of like the flu for a couple days, and then you clear it, right? You didn't progress down the serious to all the way death part of the spectrum. The study shows higher risk for glutathione deficiency are people older than 65, okay? As we age, our glutathione levels go down. Low glutathione intake, so people who have poor diets, so lacking fresh fruits, fresh vegetables, people lacking sulfur intake. So if you're not eating eggs, eggs are a great source of sulfur. Your brassica family vegetables, your broccoli, your cauliflowers, your cabbage, your bok choy, your Brussels sprouts, all of those. Males seem to have reduced glutathione at higher levels than females. If you smoke, that's depleting your glutathione. Why? Well, you're smoking, tar, right? You're creating oxidative stress with every inhalation, so you're burning through your glutathione stores, all right? And then chronic diseases. So again, ranging from type 2 diabetes and obesity to cardiovascular disease to respiratory disease to cancer to liver disease. All of those things are known comorbidities to increase risk of more severe COVID expression. So glutathione sufficiency, it is hypothesized by this author, and I would agree with him, would lead to you, if you even get infected, falling somewhere on this end of the spectrum and preventing you from ever going this way. There are other authors that would agree with that. And this study we've covered in a previous weekly nugget, and I will link to that at the end of this video and refer you to that video for a more in-depth discussion of this study. But there's a couple things I want to look at here. These authors help us understand why you and I could go into a room and be exposed to COVID, and I contract COVID and you do not. Or we both contract COVID, but I go more severe and you do not. And again, you've been around in the functional medicine world with me, so you understand that everyone's an individual, and there's a lot of individuality that plays a role here, and that's exactly what these authors are saying. If the two of us went into the room and were exposed, if you are A, you walked in with a low inflammatory status at baseline, meaning, hey, you probably eat a good diet, you probably get good sleep, you probably exercise, and you probably don't have any comorbidities. But I walked in and I have one or more comorbidities, and I maybe eat a standard American diet, and I exercised in high school once. So that would make me, just from the start, before we even walk through the door, I am set up biologically to be more susceptible to the infection. All right. Well, same thing. What if this chart is just about glutathione status? If A is optimal glutathione status and B has suboptimal or deficient glutathione status, like we've talked about on this whole call so far, A is going to be better equipped to defeat or avoid contracting SARS-CoV-2, whereas B is going to be more severe likely than A. Severe could be showing mild symptoms, whereas A was asymptomatic, or severe could be all the way down to death. So how do we fight this? Well, this paper is talking about there's many stages to the COVID infection. And so first, it's important to understand where the person is in the infectious process. So if you're not infected and you're just going out in public, you're probably looking to prevent infection. Well, then these are the things we want to do to prevent infection, right? A good foundation, nutrition, diet, exercise, that sort of thing. Antioxidant support. Antioxidant, that sounds familiar. Glutathione, right? Support natural killer cells in Th1. Oh, glutathione. Anti-inflammatory support. Oh, glutathione. Once we're infected, all of those become important, except for the anti-inflammatory support, because we may not want to put out the fire that we're trying to make to kill the infection. If we get beyond the initial infection phase, the virus takes a hold and inflammation escalates, then we need more antioxidant support, right? And then in the recovery phase, same idea. So what would be something that fits in there? Boom, glutathione, right there, okay? So glutathione, you can see this arrow goes all the way across. And you could take glutathione itself, or you could take N-acetylcysteine, which is a couple steps away from glutathione, your body converts it to it. So either way, they are both appropriate no matter which part of the infection you're in, from prevention to early infection, late infection recovery. And the authors show us down here how glutathione is helpful. We have glutathione or N-acetylcysteine, which becomes glutathione. Look, it inhibits lung inflammation. It inhibits oxidative stress, right? And by inhibiting oxidative stress, you're inhibiting lung inflammation, you're inhibiting scar tissue formation, you're inhibiting thrombosis and netosis, which is the formation of clots. So early on in the COVID discussion, right, in February and March, ARDS was the big concern. And more recently, doctors on the front lines have said, well, respirators aren't the right move, and people aren't dying of ARDS like we expected. Well, in Italy, they did autopsies of deaths against the WHO's recommendations, and what they found is that the Italians that were dying from COVID had massive amounts of thrombosis throughout the body, or massive amounts of clotting from large to small vessels. And so if we can prevent the clotting, we may be able to prevent death. And one step away from the clotting is preventing the oxidative stress, which glutathione does for us. So lastly, like we've said a couple of times, glutathione promotes Th1 and natural killer cell responses, which we need to push back against all of this. Glutathione or N-acetylcysteine can be taken orally. They can also both be nebulized and taken that way. There's lots of research on oral use, and there's not as much research on nebulized use of them, but there's some, and it's encouraging early on. And so again, you could take it orally and hit the system and let it be broken down by the gut and reassembled. You could take liposomal forms, which are absorbed through the oral mucosa, and hit the system more readily without that disassembly, reassembly. Or the nebulized glutathione and or NAC, you're inhaling right to the lungs. So if the lungs are the primary area or the sinuses are the primary area of concern, nebulizing it sounds like a good idea. So this is a discussion of glutathione and its importance for every mammal on Earth, not just humans, but for every human, and especially every human who's worried about being infected. If this conversation was interesting to you, then I suggest you read my book called The Autoimmune Answer, which is can be found on Amazon. And in that book, I talk more about the immune system and more about autoimmunity and glutathione and how all of this works together. So check that out. I'll link to that at the end of the video. Any questions?
I do want to ask, so like you have me on glutathione right now, and now I don't want to stop taking it ever.
Yeah.
But can you do that? Can you just stay on it forever? Or diet?
Yeah, yes and no. So you'll see here that, so really when you draw a diagram, you could have arrows going in so many ways that you don't see a diagram anymore because it's black, right? But one arrow that is here is this. And so the higher your TGF-beta, the lower your glutathione, because you need the glutathione to put that out, okay? So the more oxidative stress someone has, or the more fibrotic tissue they have, or the more myeloid-derived suppressor cells they have, the more TGF-beta they're producing. So the more glutathione they need, because the more they're knocking down their glutathione. So to answer your question is, it depends. So we could test for TGF-beta over time, or glutathione over time, to answer your question at the time that you have it, right? So one of the reasons you're on it is because your initial testing for the TGF-beta was higher than we want to see, right? So glutathione is knocking that down for us.
Yeah.
Is one of our targets.
Okay.
Also, you are more inflamed than we want to see, which drives up MDSCs, which drives up TGF-beta, which inhibits your glutathione, right? So we can draw the arrows until we fall asleep, but
Yeah.
Does that
Yeah.
make sense?
Yes, very much. So yeah.
So, so at times, I've had times with patients where I'm like, you don't take glutathione anymore, right? Because their TGF beta was lab low, and it's not that we don't want any TGF beta. We need some. We don't want lab low levels. We just don't want lab high levels, right?
Okay.
So there's homeostasis there, and when we get to that point, then we would say, okay, maybe keep this in your cabinet, but eat lots of sulfur-containing foods,
Yes.
right? And then we can retest in the future and say, yay or nay right now.